I'm Dr. Robert Jones, and this is the Ultrasound-Guided Vascular Access Introductory Lecture. At the completion of this lecture, the student should be able to describe in-plane and out-of-plane approaches, discuss limitations associated with each approach, define ultrasound assistance and ultrasound guidance, demonstrate in-plane and out-of-plane approaches on a vascular access phantom, and discuss site selection and technical considerations for both peripheral and central venous access. So here's a $64,000 question. Why use ultrasound guidance? If you look at central line placement, there are about 5 million cannulations performed annually in this country, and the complication rate has been reported to be about 15%. So the bottom line is there's about 750,000 complications per year associated with central line placement. Now if we look at the complications, they include arterial puncture and hematoma, pneumothorax, chylothorax, pericardial tamponade, great vessel injury, and even death. So while some of these complications may have been minor, if you look, there's a significant number of complications that have a high degree of morbidity, and there's also mortality associated with this procedure. Just keep this in mind. Complications with central lines go beyond hematomas and pneumothorax. There are some serious complications and even death associated with this procedure. Performing a central line using a surface landmark approach, it's important to remember that our technical approach is going to be guided by anatomic generalities, but it's important to remember that everyone is different, and this is what's going to potentially lead to problems. So let's take a look at some anatomic variants in terms of the internal jugular vein and common carotid artery relationship. If you look at some of the older anatomy books, they described a fixed relationship between the internal jugular vein and the common carotid artery, where it's been stated that the internal jugular vein is going to be anterior and lateral to the common carotid artery. And this is how our technical approaches have been designed when using a surface landmark approach, using this anatomic knowledge. However, ultrasound has given us the ability to dynamically look at these relationships, and a recent study showed that this relationship was only true in 7 out of 10 people. That means in 3 out of 10 people, this relationship is not going to be true. So you could see how you could get yourself into trouble or have technical difficulties when performing a surface landmark approach. Now, when looking at reasons for a difficult cannulation, sometimes it's going to be obvious, sometimes it won't be obvious. In patients who are morbidly obese, have neck deformities, have neck rigidity, they've had prior surgery at the cannulation site, they're at high risk for internal jugular vein thrombosis, such as a cancer patient, they're significantly hypovolemic, or you can't place them in a good position. On those patients, it would be relatively apparent that there's going to be a potential for a difficult cannulation. Have you ever gone into the room to put in a central line? You look at the patient, they're thin, you think to yourself, oh, this is going to be a slam dunk, and the next thing you know, you're struggling to complete the procedure. And that's the bottom line. You're not always going to be able to predict which patient is going to be the challenge. I look at patients as being much like Cracker Jacks. There's always going to be a surprise inside every one. Unfortunately, when you're performing procedures, that surprise is never good, and this is where ultrasound guidance is crucial. Let's just briefly look at a couple cases that had central line complications. This was a 22-year-old male who had been admitted to the hospital recently for a severe skin infection. During the initial hospitalization, they had attempted to place a right subclavian catheter, but were unsuccessful in doing that. The patient subsequently had a right internal jugular catheter placed, and the patient had been complaining of dyspnea that had been going on since the hospitalization. It was noted on a repeat chest x-ray that the patient's heart size has dramatically increased as compared to the one on admission. Because of the acute change in heart size on the chest x-ray, a bedside ultrasound was performed, and it was found that the patient had a large pericardial effusion with evidence of tamponade physiology. The heart is, it can be seen swinging within the pericardial sac, and you can see that there's diastolic collapse of the right ventricle. And this was all a result of the central line placement on the patient's admission. What happened was there was injury to some small vessels high in the mediastinum. These vessels continued to ooze, filling the pericardial sac. Despite needle drainage of this fluid collection, the patient continued to have oozing, and the fluid reaccumulated within the pericardial sac, and this patient ultimately had to go to the operating room for a thoracotomy. Here's another case. A left subclavian catheter was placed here, and it was noted in the procedure note that there was some difficulty in obtaining venous blood. When the radiologist looked at the post-procedural film, it was noted that the course of the catheter was not what would be expected, and you can see that instead of coming along this way, into the superior vena cava and into the right atrium, you can see that this has a very aberrant course. It turned out that this catheter, or this catheter, goes through the left upper lobe and enters into the pulmonary artery here. Again, this is not a minor complication. So don't be a dinosaur. Use ultrasound. I think the physicians that are most resistant to using ultrasound are going to be the seasoned clinicians who will always tell you, I don't need to use it, I never have complications. But the bottom line is, you never know when you're going to have complications, and when they happen, they can be pretty significant and devastating for the patient. Let's take a look now at some key ultrasound essentials. What can ultrasound do for you? It can help you to localize an appropriate vein for cannulation. It can help you to determine the course of the vein as well as patency. It can tell you if there is a DVT present that would preclude cannulation, and it can help you to determine the best approach for cannulating that target vessel. During this lecture, you're going to hear me use the terms ultrasound guidance and ultrasound assistance. Ultrasound guidance means that under real-time direct visualization, you're going to watch the needle enter the vessel. Ultrasound assistance means you've used ultrasound to help you mark the location of the vessel and its course, but the procedure is done without ultrasound. So here's an example here of a patient where a peripheral line is placed under ultrasound guidance. Here you can see the vessel in its long axis, and here you can see the needle real-time entering the vessel. Let's look at the one operator versus two operator technique. There have been a couple studies in the literature. Both have shown that there's no difference in the time to complete the procedure between the two techniques, and no difference in morbidity and mortality between the two techniques. So the bottom line is, master the one operator technique. Don't bring a second person into this procedure. In a busy ED, it's very unlikely that you're going to be able to find somebody to assist you on a routine basis. So use the one operator technique from the beginning. With needle control, you've got two choices. You can use a freehand technique, or you can use a mechanical guide like we see here. The nice thing about the mechanical guide is that it stabilizes the needle, but the downside is that it fixes the trajectory of the needle, and this is going to limit your approaches to the vessel. In most bedside vascular access procedures, the freehand technique is going to be used, and that's what I would advocate. Don't underestimate patient positioning. When you're scanning the vessels, see what the effect of head turning is with the internal jugular and common carotid relationship. The same thing applies in the groin. Frog leg the patient and see how that affects the relationship of the artery and the vein. Here you've got a patient, and you can see that there's a change in the relationship between the internal jugular and the common carotid artery, just as a result of head turning. And this would affect how you're going to approach that vessel. So don't underestimate the power of patient positioning. Obviously, this is a simulation here since I'm not wearing any gloves. But when you're holding the transducer, make sure that you hold it in a comfortable position with your hand lightly affixed to the patient. You don't want to hold this like a hammer. This is going to make the procedure much more difficult to perform. Avoid using a heavy-handed approach. If you look at the vessel up here, it's completely collapsed due to transducer pressure, and it doesn't take a lot of transducer pressure to collapse the vein. But you can see that by lightening up on the transducer, that the vessel is much more apparent and would be easier to access. What is a normal vein going to look like? A normal vein should be anechoic, and it should be easily compressible. What is a DVT going to look like? Well, the vessel is going to be echogenic, and it's going to be non-compressible. Here you can see a vein filled with thrombus, and it's non-compressible. This would not be a good target vessel. Have you ever put in a central line, aspirated as you're going in, got nothing, and then got venous return on the way back? Well, that's not uncommon, and that's due to the fact that even though we're dealing with cutting needles, you can build up a tiny rim of soft tissue over the needle tip that's going to prevent easy venous entry. You're going to cause significant tenting here, almost to the point that you're going to end up going through the back wall. And blindly, this is what frequently happens. But it still is possible even when you're doing ultrasound guidance. So how can you prevent this or minimize this? You want to make small controlled jabs as you go in. You can have normal saline in the syringe, and you can instill small amounts at intervals into the soft tissue to kind of free up the soft tissue that's getting built up around the tip of the needle. As you get close to the wall of the vessel, you can then make a small jab to go in. But you just have to remember, even with ultrasound guidance, there's still a risk of going through the back wall. So you have to pick your targets and choose your targets wisely. Because here you can see my needle path is in line with the common carotid artery. So if I go through this, I'm going to hit the common carotid. And so you can see here how close we got, before, we were able to access the vessel. We did not double wall here, but you can see that it was very close. So remember, make small controlled jabs, instill normal saline if you see you're building soft tissue in front of the needle. And if you get up to the vessel, you're tenting it, back up a little bit, instill some saline outside of the vessel, and then make a small jab to get into the vessel. In terms of choosing a vessel, regardless of the approach, the vessel has to be assessed for patency and absence of thrombus. You want to make sure that the overall course of the vessel is noted and that it's in line with how you're going to approach it. You want to be able to look at adjacent arteries, nerves, lymph nodes, and other key structures and make sure that they are not going to be in the anticipated path of the needle. And you have to remember that anytime you perform a procedure, there's always a risk, even with ultrasound, to double wall the vessel. So you have to accept potentially hitting what's on either side of the target vessel. Remember, assess both sides of the patient, since frequently there can be a difference in vessel caliber and quality from one side to the other, and don't be afraid to position the patient to see how that affects the relationship of the target vessel to surrounding structures, and see if that makes the approach more doable for you. Let's take a look at spatial orientation. And the orientation of the transducer to both the needle and the vessel is going to be controlled by you, the operator. And so the decision on which approach you're going to use should be based on sound, anatomic, and technical considerations, and that's what we're going to go over here. Let's take a look at this patient here. If I was going to do an internal jugular cannulation on this patient, you've got a couple different approaches. You've got a posterior, a central, or an anterior approach. Looking at this anatomic relationship here between the internal jugular and the common carotid, I would choose a central or middle approach here. A posterior approach would put me in line with hitting the common carotid if I double walled the vessel. Looking at this relationship here, if I used a central or middle approach and I double-walled the vessel, I would end up going into the common carotid. However, this would be a better, posterior approach would be a better option in this patient here because I could come along in this direction under the muscle belly, enter the internal jugular vessel, and if I double-walled it, not end up going through the common carotid artery. Don't forget to look at both sides. Here we've got the left internal jugular vein on the patient. Here's the right internal jugular vein. Which one would you rather approach? Obviously, you'd want to take the right internal jugular vein because it's much larger. Both of them are free of thrombus. Both of them had a nice straight course, so there was no other confounding issues. But looking at the size, this would be the preferred target here. Needle visualization is going to be key because anytime you're doing an ultrasound-guided procedure, it's all going to be based on visualizing the needle. So there are going to be things that are going to affect how the needle is visualized. What the angle of the needle entry is, what type of needle, and what the bevel direction is. Keep in mind that the needle is going to be best visualized when it's closest to perpendicular to the sound wave. Here you can see the needle much better. This needle is being entered in at an angle that's closer to perpendicular to the sound wave as opposed to this one. So just keep that in mind that if you're at an angle that's far away from perpendicular, needle visualization may be suboptimal. If you have access to them, there are needles that are echogenic and have enhanced and will have enhanced visualization due to either Teflon coating or roughing of the edge or the tip of the needle causing scattering. Here you can see an echogenic Cook echo tip catheter here, and here you've got a regular needle here. So if you've got access to these types of echogenic needles, they are nice. In terms of machine location and setup, you've got to make sure that the machine is set up so that you can easily visualize the screen. You don't want to have to be looking over your shoulder or have the machine in an awkward position. The success of this procedure is going to be based on you seeing the vessel and the needle on the screen. So make sure that everything is set up the way you want it before you begin the procedure. For vascular access procedures that we're going to be discussing here, you're going to want a high frequency transducer. The one most commonly used for ultrasound guided vascular access is going to be the high frequency linear transducer. However, you could also use the high frequency pediatric curvilinear transducer. But the one that is most commonly used is going to be this transducer, the high frequency linear. If you're doing ultrasound guided procedures, you've got to use the sterile transducer cover kits. I would avoid, if at all possible, using sterile gloves because you're going to have to deal then with the fingers and it makes it more awkward. These are nice. They contain a sterile sheath. They contain rubber bands to hold the sheath in place, and you also have sterile gel. These are easy to apply, and you can do this with one or two operators. If you use the one operator technique with the transducer in the holder on the machine, before you put on your sterile garb, go ahead and put ultrasound gel on the transducer. When you open up the sterile transducer kit after you've got your sterile garb on, what you can do is basically like rolling up a sock. You can roll up the transducer sheath, put your hand inside of it, and then grab the transducer out of the holder on the machine, making sure that you don't contact any other non-sterile areas. Pull that or remove that from the holder, fully elongate the transducer sheath, put the rubber bands on, make sure that you've got gel still over the footprint of the transducer, and now you can apply the sterile ultrasound gel to the outside of the sheath. Let's take a look now at the different sonographic approaches. First, let's look at in-plane versus out-of-plane techniques. In-plane technique means that you're going to see the needle in its entirety as it approaches the target vessel here. And you can see here is the needle in its long axis approaching the vessel here. So this would be a long axis in-plane technique. With an in-plane technique, the nice thing is that you're going to see the needle in its entirety, so it's less likely that you're going to have a double wall puncture or that you're going to lose sight of the needle tip. And this in-plane technique can be done in either a short, long, or oblique axis approach. For vascular access, the in-plane technique will be done using either a long or an oblique axis approach. Helping you to look a little further down the road here, these are going to be the same principles that you use with other ultrasound guided procedures. Here is a drainage of a tendon sheath fluid collection, and you can see that this is an in-plane technique here. You can see the needle entering the fluid collection here, and this is going to be used to aspirate the fluid out. The nice thing about the in-plane technique here is that you can see the needle tip in its and the needle in its entirety, so you know your exact location of the needle tip, and here you can see the fluid being drained. Here was an intravenous drug abuser who had a septic shoulder, and here you can see an in-plane technique where the needle is going in to the septic joint and the fluid is going to be drained. So remember, you start off using this for vascular access, but then you can branch out into other procedures using these same approaches. Here we have a long axis in-plane approach. So here, the needle, the beam, and the vessel are all going to be in line. So you have the vessel in its entirety here. You're going to end up having the needle coming in this plane here, so everything is going to be aligned. You'll see the needle in its entirety, and the needle is going to enter in the middle of the short face of the transducer. Here's another look at the long axis approach. You've got the transducer, or you got the needle entering in the middle of the short face of the transducer. The needle is in line with the ultrasound beam, and the beam is in line with the long axis of the vessel. So here you can see on the ultrasound image the vessel in its long axis, and you can see the needle in its long axis, and here's the needle tip approaching the target vessel. Here's an example of a femoral venous cannulation using a long axis in-plane technique. You can see here's the needle in its long axis, you got the vessel here in its long axis, and you can see that the needle now has entered the vessel, and you have no doubt that the needle is in the vessel because you can see the tip here and you can see the needle in its entirety. That's the big advantage of this technique. Well, since there seems to be a lot of advantage to this type of an approach, you may think to yourself, boy, why use any of the other approaches? And the problem is aligning the very thin ultrasound beam with the very thin needle over a vessel can be a challenge. If any of the three are out of alignment, you're not going to end up with a good ultrasound image. And here you can see here that the needle and the beam are no longer aligned. You can kind of see some indirect evidence of movement, but look what happened during the time that the visualization was lost and the needle was continued to be advanced. You can see how far you entered into the soft tissue. So that's the potential downside of this procedure, is that it takes a lot of technical skill to have all things aligned, because if things are not aligned, you're going to end up with an image that is such as this, where you don't see the needle or you don't see the vessel, and this can be dangerous. So a key thing to remember: if you don't see the needle, don't advance any further. You've got to then realign the transducer with the needle before moving any further. The answer is never to advance the needle further. That will not help you reobtain needle visualization. An oblique axis approach is also an in-plane approach, or an in-plane technique, because you're going to see the needle in its entirety entering the target vessel. The nice thing about the oblique approach is that you're seeing the needle in its entirety, but you're also able to then see adjacent structures around the target vessel. You're going to, in order to perform this procedure, again, you're going to enter with the needle in the middle of the short face of the transducer. Example here on a phantom of an in-plane oblique axis approach. You can see here's the needle. You're seeing the needle in its entirety approaching the target vessel here. And you can then see it entering the vessel here. Here's a video I showed you before. This is an example of an oblique axis in-plane technique, because here you're seeing the needle in its entirety. We had entered in the middle of the short face of the transducer. From a technical standpoint, this was probably not the best approach because, again, this needle is in line with the common carotid artery, which is not ideal. Now, out-of-plane techniques are going to be the most common approach used in emergency medicine, and that's because it's easier to perform at first. However, there's a greater chance of going through the back wall of the vessel, since you can't always guarantee that you know the location of the tip of the needle. So here is an out-of-plane short axis approach. So you're going to have the needle and the vessel are going to be at 90-degree orientation. What you're going to end up seeing is the short axis view here of the vessel, because you're perpendicular to the long axis of the vessel. The needle is going to enter in the middle of the long face of the transducer, because basically you're dealing with a centering process here. That if you've got this vessel in the center of this rectangular image here, then you would be able to assume that if you enter here in the middle of the long face of this transducer and continue to go in, you're going to eventually hit this target vessel. An important thing to remember here is that unlike in diagnostic ultrasound, where transducer indicator on a short axis approach is always to the patient's right, here the indicator is always going to be to your left. That way movements you see on the screen are going to correlate with transducer movements. That's a key point, because you may be approaching a target vessel such as a femoral vein where you're looking up towards the patient's head, versus an internal jugular approach where you're standing at the head of the bed looking down towards the patient's feet. So make sure that the indicator is always to your left. Important to remember that you're only going to see what's directly underneath the transducer where the beam is. So you could take this needle, as you see right here, you're seeing one little blip here where it's passing underneath the beam here. I could continue to advance this needle and bury it to the hub, but if I keep the transducer static in this spot, this image is never going to change. And that's an important thing to understand. Here we're just moving that needle in further, but this image is never going to change. It's only going to pick up what's directly underneath the transducer where the beam is. I like using a dynamic short axis approach where either you slide or angle the transducer so that it follows the needle from the soft tissue into the vessel. And you can see here there's a coordinated movement of the needle and the transducer. That way you're going to have the best chance possible of visualizing the needle tip. Here's an example here of a dynamic short axis approach on a phantom. And you can see here that we're sliding the transducer along with the needle. And you know that you're following the needle as it's moving, because you can see that the depth is changing as we approach the target vessel. And you can see that we're moving closer and closer to the vessel. And you can see a little bit of tenting. And at this point, you'll make a short jab and enter the vessel. It's important when using this technique that you stay midline. If you look here, what's happening is, even though we started off directly over the vessel, we've kind of slid off to the side here. And so you can see here that we're now missing the vein because we've started off here but we've slid off to the side. This is why the dynamic approach is helpful, because it will allow you to pick up these types of deviations early, allowing you to redirect and stay on course with the target vessel. When I use a dynamic short axis out of plane technique, I like to use what I call a walk ahead technique. So what I'll do is I'll dynamically move the transducer along with the needle. As I'm approaching the target vessel, I'll stop for a second in terms of moving the needle, move the transducer ahead until I lose visualization of the needle, and then come back to it. The first area where I see the echogenic foci of the needle, I can be fairly certain at that point that that's the needle tip, and then I can continue moving on. And you can see here that here we've got a short axis cannulation. Even though ideally you want to enter here, I entered a little bit off to the side, but that's still okay. My indicator's towards my left, so I know which way to redirect in order to get back to midline. And you can see here we're moving towards the vessel, and you can see for a second that you lose visualization of the needle here because I walked ahead and then came back to the needle. So that way I have an idea as to where the needle tip is. So when you're practicing on the Phantom, try this walk ahead technique. I think it's very useful in locating the needle tip, and this will help you in terms of correctly placing the needle tip within the center of the vessel. Here's another example on a Phantom using the walk ahead technique, where I'll move ahead of the needle tip and then come back to it. So you can see there's needle tip, we lose it, I come back to it, I know then that that's a tip, get closer to the vessel, walk ahead of it and come back. So practice this technique on a Phantom. I think you'll find this to be very helpful. I want to reiterate a key point here. For whatever reason, during whatever approach, if you can't see the needle, stop advancing it. You've got to make corrective movements with the transducer in order to visualize the needle. If after multiple attempts you still can't find the needle, the solution is never to advance it. Your best bet is to remove the needle and start again. Let's now look at some specific target vessel approaches. Now, femoral vein access could be done using either in-plane or out-of-plane techniques. You could use an in-plane long axis approach. You could also use an in-plane oblique axis approach, or you could use an out-of-plane short axis approach. So you've got a lot of flexibility here with the femoral vein. Now, the internal jugular vein also can be performed under a variety of approaches. You could use an in-plane oblique axis approach, which would be the posterior approach. You could use an in-plane middle approach, which would be a long axis approach, or you could use a out-of-plane short axis approach, which would be a middle approach also, and this is probably the one that's most commonly used in emergency medicine. But again, this is the one where visualization of the needle tip can be more difficult. We have an out-of-plane short axis approach here to the internal jugular vessel. You can see that you're perpendicular to the long axis of the vessel. You've got the indicator towards your left. You're going to enter in on the middle portion of the long face of the transducer, and what that'll give you here is this type of a view. You can see the needle is coming in this line here. You're only going to see the part of the needle that's directly underneath the beam, and here you can see the blip as the needle enters the vessel, and there it is again. Here we have an in-plane oblique axis approach, or the posterior approach to the internal jugular vein. This is the one that I like to perform. And the way that this can be performed is you place the transducer on the neck just above the clavicle in a short axis plane. You bring the lateral border of the transducer up in a cephalad rotation about 30 degrees. You enter with the transducer at the lateral border of the sternocleidomastoid muscle, and the transducer is going to enter in the middle of the short plane, or the short face of the transducer. You're going to slide underneath the sternocleidomastoid muscle, which you see here. You don't want to go through the muscle belly, and you're going to enter the internal jugular vein. So this is a long axis approach. This is a in-plane approach because you're going to see the needle in its entirety. Here we have an in-plane oblique axis approach, or the posterior approach to the internal jugular vein. This is the one that I like to perform. And the way that this can be performed is you place the transducer on the neck just above the clavicle in a short axis plane. You bring the lateral border of the transducer up in a cephalad rotation about 30 degrees. You enter with the transducer at the lateral border of the sternocleidomastoid muscle, and the transducer is going to enter in the middle of the short plane, or the short face of the transducer. You're going to slide underneath the sternocleidomastoid muscle, which you see here. You don't want to go through the muscle belly, and you're going to enter the internal jugular vein. So this is a long axis approach. This is a in-plane approach because you're going to see the needle in its entirety. Peripheral venous access using ultrasound guidance has become very popular, and it does minimize the need for central line placement in a lot of patients, but you have to choose the target vessel wisely. Most commonly, either the basilic or the deep brachial veins are approached, but I'll show you some other techniques that could be used on these patients. But it's important to remember, while this is a great thing to do in order to minimize the need for central line placement, we don't have an ideal catheter yet for these venous cannulations. Let's take a look at some special considerations here. Remember, the vessels that you're going to be targeting with ultrasound guidance are deeper, so you're going to need a longer catheter, and this is where problems occur. The longest catheter that you're going to have access to, where you've got the angiocath over the needle, is usually about 1.88 inches to 2 inches in length. And the problem becomes is, if you go after a target vessel that's relatively deep and you've only got a few millimeters of that needle tip in the vessel, any movement of that arm is going to lead to the catheter being pulled back and losing your desired placement. Therefore, subcutaneous infiltration is common in these types of lines if you don't choose your target vessels carefully. Therefore, I always advocate that tissue toxic medicine should never be placed through these lines. In terms of transducer preparation, I will apply a very thin film of gel to the footprint of the transducer, and then what I'll do is I'll cover the transducer with opsite, and then I'll use a very thin film of sterile gel or Surgilube on the skin, and you want to make sure that you don't get gel on the entry site itself. In terms of needle entry, remember you've got a choice of angles. You could come in at a relatively steep angle, maybe about 45 degrees, or you could come in at a relatively shallow angle. If you come in at a relatively shallow angle, this is going to leave you with less catheter within the vessel, meaning that your chance of subcutaneous infiltration is going to be greater. You don't want to come in too steep because it's going to be more difficult to feed the angiocath over the tip of the needle and get it to go into the vessel. So I would usually advocate going in at about 45-degree angle. Here's an in-plane long axis approach to a superficial vein within the mid-forearm, and you can see here that the needle is being entered in the middle of the short face of the transducer, and here you can see the needle tip. Here you can see the bevel of the needle right here, and you can see that it's centrally located within the vessel, and at this point the angiocath is brought over the needle and the vessel is cannulated. Here is a short axis approach to a vessel within the forearm. If you look, it's actually not that deep, which is good. You don't want a vessel that's any more than a centimeter deep if you're going to use a 1.88 or 2-inch catheter. If you're going to do something peripherally deeper than that, then you would need to consider using a Seldinger technique and using a central line catheter so that you don't end up with subcutaneous infiltration. But this is a relatively superficial vessel here, so we center over the vessel and enter in the middle of the long face of the transducer, and here you can see the needle within the vessel. Let me talk briefly about choosing a vessel. I think the most common peripheral targets in emergency medicine are going to be the deep brachial or the basilic veins. And while they're relatively consistent and they're large targets, they tend to be deeper, and I think the chance of subcutaneous infiltration with these vessels is going to be greater, particularly in an obese patient or someone who's got a lot of flabby skin. What I have started to do more and more of, and I've had more success with this, and the lines are more stable, is to start off in the antecubital fossa, in the short axis, find the basilic vein or the deep brachial veins, and then move the transducer distally into the forearm following these branches. So here we are in the antecubital fossa, and you've got basilic over here, you've got the deep brachial veins here. What I'm going to do is follow the vessels into the mid forearm, and you can see right here, here's a nice vein, relatively superficial, has a nice straight linear course, and so this is a target vessel that I went after, and this could be approached in either a in-plane or out-of-plane technique. Even if you needed this for a CTPE protocol, as long as you're between the mid-upper arm and the mid-forearm, you've got a good target for dye injection. So keep in mind, try and use a vein within the forearm. They tend to be more stable, they're more superficial, and I think that you'll end up with better target choices here. This concludes the introductory ultrasound-guided vascular access lecture. I would advocate now that you use the vascular access phantoms and practice these techniques as much as possible. Because remember, while ultrasound will decrease morbidity and mortality associated with these procedures, that's in the hands of a skilled operator. In somebody who has little familiarity with ultrasound and little experience with it, your chance of having operator errors are fairly significant. So remember, practice as much as possible on phantoms.